Hello, hi, welcome to our programme, Answering the Call, Practical Strategies for Improving Early Diagnosis, Patient-Centred Management in Primary Care. Thank you for Anna Kaplan and Anna Vajo-Bukasius and Alan Kaplan for last week talking about early diagnosis and risk assessment in COPD. Today we're going to focus on the non-pharmacological management of COPD. Today's session is a partnership with the COPD Foundation and IPCRG. So there we are. I'd like to introduce myself. My name is Clare Cook. I'm a respiratory physio who works in the southwest of England and also supports some programmes of work with the Primary Care Society, both with IPCRG and with PCRS. And I'm privileged to be joined today by my colleague, Dr. Sally Singh.
Thank you, Claire. My interest is very specifically around pulmonary and cardiac rehabilitation, and obviously today's focus is going to be pulmonary rehabilitation. Like Claire, I'm based in the UK, a little way away from Claire. I'm up in the Midlands at the University of Leicester.
Lovely. So we'd like to take the time today to kind of achieve two learning objectives. We'd like to really highlight the importance of non-pharmacological strategies in targeting breathlessness, recognising that this reduces mortality and morbidity by enabling patients to participate and be less burdened by their COPD, with strategies to improve quality of life and ensure that people have an improved lived experience with COPD. We'd like to outline how it's important to make a plan of supported self-management to improve the disease knowledge that the individual understands, and also strategies so the patient's got a better experience. Particularly pertinent with individual COPD is the burden of breathlessness, so commonly experienced by individuals. Often our key story, our narrative that our patient tells us that's key to diagnosis can often be that story that continues through their lived experience with COPD. This is an image that lots of us can relate to and lots of our patients can relate to. What we're going to focus on today is thinking about non-pharmacological strategies that can reverse the spiral of decline, that can lead to driving deconditioning. So if we think about our patient, they can be in that experience of that blue cycle. So they're having, as their COPD lung function progresses, but also as they become deconditioned and less confident to manage their condition, their breathlessness can drive anxiety, and it can affect not only activity, but also even low activity levels like dressing, washing, and normal activities of daily living. And we so often hear that story that the experience of breathlessness and the burden of COPD becomes more and more prevalent through day-to-day living, and that decline becomes more progressive. Equally, that deconditioning can result in more propensity to have exacerbations and be more burdened by those exacerbations, which understandably results in poorer quality of life, restriction in socialisation, restriction in independence and autonomy, and unfortunately a risk of other concomitant health problems. The great thing is that this spiral for many is reversible, and also the key message here is the earlier we intervene, the more successful we can be in reversing that decline. We need to empower people to have confidence to do both physical activity and exercise, to have increased confidence around their own personal self-care and disease management, and also to physically increase their exercise tolerance and reduce that experience of breathlessness. One of our key interventions here to do this is pulmonary rehab, and that's drawing together a lot of non-pharmacological intervention. So we think about targeting breathlessness in COPD as a kind of umbrella. We know that absolutely rooted in this is smoking cessation. It's the primary way of reversing lung decline. Smoking cessation we often think about from a pharmacological perspective, but it's also critical that we think about how our conversation structure, our support and our listening skills help patients to engage and be successful with smoking cessation. We'll go on in detail later in this afternoon to talk about pulmonary rehabilitation as a independent intervention that Dr. Singh is going to take us through, and thinking about some of the challenges and opportunities that pulmonary rehab can give us. It's also important to recognise that supported self-management is about empowering individuals to have mastery of their condition, and this is also rooted in good mental well-being, and programmes that include supportive and psychological support are also more likely to be more successful and have better engagement with our patients. We're going to briefly touch on the importance of oxygen therapy and how an understanding and confidence in the use of oxygen can improve patients' outcomes, particularly when participating in activity. And we're going to have a brief look at some of the simple tools that are available that patients can use at home, and talk about some of the array of materials that are available that we can signpost our patients to, so they can access non-pharmacological techniques to reduce their breathlessness, but also recognise that all of these things take practice, and COPD is a variable condition. So it's often thinking about, as healthcare professionals, we need to intervene and support our patients through these programmes. So we can't think about smoking, about COPD care, without considering the impact of smoking. And what's really important is when we have conversations with patients, when we're discussing any non-pharmacological conversation, we're advocating the impact and benefit. Now, with smoking, these benefits are really clearly outlined, which the evidence base is not always there to talk about the benefits that that patients will realise with non-pharmacological intervention. But it's really important we think about understanding what the patient's goals are, and how we can relate some of the changes they might experience by engaging in certain therapies. So when we talk about evidence as well, we talk about the importance of the evidence base that underpins smoking cessation, and how important that is for breathlessness and improving lung function in our COPD population. What we absolutely know is that down here, rooted in this grade A evidence, is the importance of behavioural counselling and supporting patients with resources that they can access. And that's where in primary care, our responsibility to ask, advise and act is absolutely integral, ensuring that patients can engage. And that same principle of a positive inquiry-based consultation is really important when we're introducing patients to non-pharmacological principles. So all the knowledge that you apply when you're helping people with smoking cessation and how you construct your conversations can be used when we're having non-pharmacological conversations as well. And recognising that the behaviour support is 4 times more likely to help people with tobacco dependency to be able to quit. So it's really important that we think about that partnership between psychological support, behavioural support, in order for people to be successful. When we think about structuring conversations, we often use motivational interviewing to aid smoking cessation. We ask people how important it is for them to be free from smoking, and then we rank that 0 to 10. And this is a really familiar conversation that you'll use all the time in primary care, and it helps patients to start to articulate and prioritise how they are feeling about their tobacco dependency. And then from this conversation, you can build and signpost the support you give them according to the level of answers they're giving you. So this isn't about knowledge, this is about confidence and about importance. And that can be really helpful when we're helping patients with complex health conditions prioritise what it is they want to work on. We can then also tailor our information and our signposting to make sure that we're supporting patients with their problem, and that we're making sure that we're patient-centred in not just prioritising what's important for us, but the symptoms and problems that are most burdening our patients. So as we think about building our conversation and motivation and interviewing, we're thinking about those key skills of listening, reflecting back and listening again, making sure that this conversation is conducted with permission for the patient. And actually, if the patient's giving us information that they're not ready to quit smoking, it's going on and thinking that we ask permission to keep that conversation going. And we ask them what other problems or considerations might be important to them, so we know that when we're giving information signposting, it's personalised. Something else that we often go into conversations with is the benefits of pulmonary rehab. We're going to discuss the importance and value of this later in detail, but it's important to recognise that this, again, is a conversation that patients may be nervous about. They may feel unsure about what the intervention's offering them, and making sure that when we introduce that initial conversation around pulmonary rehab, that we as practitioners are informed, so that we can guide patients to the right information about how they access that intervention, and also the high quality evidence that underpins the importance of this intervention. The impact of smoking cessation, the impact of pulmonary rehab are really, really well evidence-based, and patients can feel assured that taking that advice and engaging in those therapies will be really beneficial for them. When we talk about non-pharmacological intervention, we often think about treating breathlessness. So that persisting, enduring breathlessness that's so often experienced by people with COPD. There's not just one size fits all. There's not just one technique that people can adopt. And it's certainly not a case of, well, they try it once and then it's cracked. Patients, when patients are training to retrain their breathing technique, they need to practice and rehearse that. And these are strategies people need to access when they're under pressure. They're frightened and in anxious situations, be that in the ED room, be that experiencing exacerbations at home, being that experiencing exacerbations or excessive breathlessness when they're exerting themselves. So it's really, really helpful that these techniques are practiced when people are feeling well and when people are feeling in a position where they're not challenged. There are lots of resources available, and the COPD Foundation and IPCRG provided a gamma of tools which we can signpost patients to. And I'm really pleased to share with you that there's a new digital magazine that's going to be produced by IPCRG, going to be released at conference this week, which is providing a nice collection of workbook tools for patients to access. So we're really pleased to promote those tools. The tools, if I just go back a slide, sorry. The tools here are all about changing people's breathing pattern, giving some resistance so that they don't experience so much dynamic hyperinflation, and also fan therapy, which has been proven to aid breathlessness recovery and symptom relief of breathlessness. And also recognising that we don't just sit still and use our non-pharmacological strategies. We might move around and use different positions of ease to take pressure off the diaphragm and allow us to breathe more comfortably, and recognising that patients need dynamic ways of accessing different strategies because they're not using them all in a static position. When we're looking at giving people support, we recognise that patients often need support over a couple of sessions to gain confidence, and they also learn exceptionally well from peers. So as well as healthcare professionals, it's really important that we think about the COPD support networks that patients can access, giving them opportunity to rehearse, to revise, and also to talk with their peers around how they've used tools, because we know that lived experience of COPD can really help the confidence and knowledge of others. Pulmonary rehab is a really unique opportunity where we have a series of sessions with patients where we can revise and rehearse the techniques, and we can explore patients' questions or hesitance around things like smoking cessation. We've got the opportunity to implement motivational interviewing. But we know that pulmonary rehab is a complex service that patients can't always access. So I'm going to pass over to Dr. Singh now, who's going to explore some of the...
Thanks, Claire. I'm just going to start with this slide, which hopefully will give us a bit of context to the mechanism of action of pulmonary rehabilitation, because I'm sure you're all very familiar with that downward spiral that Claire showed earlier. And people tend to get breathless partly because they have a lung pathology, as you can see from the top left-hand corner. But also people become very anxious when they are breathless, and ultimately the panic and the anxiety can drive the breathlessness and absolutely exacerbate it. Equally, you know, when people are breathless, they avoid doing the activity that makes them breathless, in the same way that we all avoid doing anything if we've got a painful joint. So patients are exactly the same in the way that they respond to breathlessness. And just like the rest of the world, if you do less, your muscles become less fit. And so when you try and do a task, you ultimately become disproportionately breathless. So you have this mixed picture of breathlessness because of a pathology, breathlessness because of your anxiety, and breathlessness because of your deconditioning. And ultimately, pulmonary rehabilitation aims to reverse these essentially independent or interrelated vicious cycles. So it's a package of exercise training that is absolutely symptom titrated to the individual. But there are educational and self-management support packages that aim to educate an individual about their breathing, help them with the positioning that Claire's shown us, and generally reduce the fear and anxiety associated with rehab. And as Claire showed us, it's a highly evidence-based intervention. But it's not without its challenges, and some of these are person-related, and I think others are system-related. Now, theoretically, an individual should have a confirmed diagnosis of their respiratory disease, and obviously today we're talking very specifically about COPD. But very frequently, and we have audits in the UK that demonstrate that invariably people are coming to rehabilitation with possibly not even the right diagnosis or any recent spirometry. But there are also problems where people don't turn up to the assessments. People might turn up to the assessment and then they don't turn up to start the programme, or a person drops out of the programme. And some of these problems are really related to us as healthcare professionals in terms of the quality of the referral. So in primary care, we're really reliant on you as practitioners making a very robust referral and being able to answer people's questions. And I think, we've done lots of surveys in high and low income countries that demonstrate that there's a real understanding around pulmonary rehabilitation, but sometimes anxiety around referring and that conversation that you have with the individual. So I think there's a whole education piece around how we refer, how we have that discussion with patients, because clearly exercise is a pretty scary thing. And for those people that actually do make it through the programme, one of the big challenges is actually maintaining the benefits of rehabilitation. And I suspect we've all had those good intentions of doing exercise at the beginning of the year and dropped off. So, patients with COPD aren't any different to the rest of us. But I think it's important, if we are going to really try and make pulmonary rehab a success, there are some things that we can do. And I think it's beholden to us as a healthcare system to really understand the pathway, the referral processes, and really advocate strongly for rehabilitation. We need to have limited handoffs where people can essentially drop through the system and have this direct access into rehabilitation services from primary care. There's also the potential to identify patients from IT systems where they may be able to proactively identify people with the MRC grades 3 to 5 that are traditionally the target audience for rehab. I have to say, this, talking to a US audience and being involved in the American Thoracic Society, the payment and reimbursement in the States remains a constant mystery to me, but clearly there are absolute challenges around payment. And in the UK, we have to convince commissioners often that pulmonary rehab is a valued intervention. So we have to, really improve the visibility of rehab. And one of our suggestions locally is that referrers should actually visit a rehabilitation programme so they understand what they're referring into. And then you can anticipate individuals' concerns as well. So there are other ways of keeping, the momentum going around rehab. You can have a testimonials book like you might when you're leaving a hotel to say how wonderful it was, that patients can also read. Social media, I suspect, has a role to play now. And other aspects of patients' well-being may need considering. So we see multimorbid patients now, and we'll talk in a moment about psychological well-being, but there are other comorbidities that may need managing as well. But also, I think those of us that deliver a service need to be able to look at different models of delivering rehab so that we have a suite of opportunities for patients to really encourage adherence and have a flexible approach where they, if patients do drop out, they are allowed to re-enter the programme. Now, clearly, one of the things that we always talked about when I first started doing rehab, which was obviously a long time ago, were patients that were underweight. There was this real sort of pink puffer phenotype that people were very anxious about in rehab. And there's been a lot of research around nutritional supplementation. So now, we're always looking out, as we all should in primary and secondary care, for people that have a low BMI and at high risk of malnutrition. And it's not just the low BMI, it's also those that have had a significant weight loss in the last few months that we need to be alerted to, and then consider whether they need some form of supplementation. There's been a lot of interest in rehabilitation and supplementation because rehabilitation obviously is exercise based, and that has an energy demand. So we've been doing lots of research to try and see whether we can replace that for patients, but it's really challenging to add nutritional supplements to an exercise intervention. But this is a really interesting study where they asked patients to drink beetroot juice before they came to rehabilitation because it's high in nitrates, which has been shown to improve physical fitness in healthy individuals. And there's a real hint of a signal in patients with COPD. So the group on the right-hand side were drinking the beetroot juice before they came to rehabilitation. And both groups had an improvement, as you'd expect with rehabilitation, in their walking distance. But the group with the beetroot juice actually had a greater improvement. So there's some interesting studies to be done looking at how we can make rehabilitation potentially even better than it is. I talked a little bit about looking out for psychiatric symptoms or psychological disturbances. And of course, there's a number of questionnaires that can be used in primary care that are probably available on a template. And of course, we use them in rehabilitation as well. And we know rehabilitation reduces both anxiety and depression in those with both severe and moderate depression, but it's something we should all be keeping an eye out for. And this is an example of a very brief questionnaire, which is a combination of the anxiety and depression scales, the PHQ-9 and the GAD-7, but this is just 4 questions. It really helps give you an indication that things are not as well as they might be for the individual, and encourage a referral to a psychological therapy. And then oxygen therapy is probably one of the most long-standing non-pharmacological interventions compared to all the others we've talked about. And we know that the long-term administration of oxygen therapy improves survival in those with severe resting arterial hypoxemia. Now, the evidence is less strong in those that desaturate or only have moderate levels of hypoxia. And we know that in patients with stable COPD and moderate resting or exercise-induced desaturation, there is no gain in terms of delivering long-term oxygen therapy. But what we do know is that even with people with normal resting levels of oxygenation, there may be challenges when people fly. So people may need referring in for an in-flight assessment. And there are other forms of ventilatory support that are perhaps focused those with persistent hypercapnia that most likely have been in hospital with an exacerbation of their COPD. So just to summarise, we know that oxygen therapy improves survival in those with severe hypoxia. It doesn't in other groups, and it's not useful in people that are breathless. There's no association at all between people's level of oxygen saturation and their perception of breathlessness. Usual challenges with every intervention around adherence and prescription, and often in primary care settings in many parts of Europe and the States, you can't prescribe oxygen from primary care, so it needs to be a secondary care referral. So I'm now going to pass back to Claire.
Thank you. So thinking actually what helps patients to once they've been through poignant rehab to continue with that grounded knowledge about their COPD, but also about implementing those strategies that they understand. We absolutely know that patients need to understand and understand the benefit and the impact of certain therapies before people want to engage in them. That's completely understandable. And actually, when we look at the research that says why why do patients with COPD don't take up physical activity? It's because people don't perceive it's applicable to them. So a lot of our conversations are about opening the doors and about giving people opportunity to engage. And that's the real strength of peer group work as well, is that patients can have supported self-management plans where they can recognise that they can feel empowered to use the techniques that they've been taught and to sustain that improvement. The other thing that we found really important for patients is actually if they record their experience and their trajectory with things like symptom diaries, mood diaries, and goal settings, they're much more likely to sustain those behaviours that they've adopted. Recognising that no man is an island, no woman is an island, and we absolutely need to think about the network that support that patient to be successful, increasingly recognising the importance of voluntary sector, but as well as those in our home and our wider home network. They're always welcome at pulmonary rehab, and that's one of the great things about digital resources now, is it's increasingly easy to say to patients, I'm going to signpost you to these resources. Why don't you share them with your family, talk about them, and then come back to us with any questions? Because it's that rehearsal and that wider understanding that leads to mastery with our condition. We're really familiar with COPD action plans, which recognise what to do in the point of exacerbation. But it's important to think about writing accessible action plans that apply to people with day-to-day lived experiences and their usual, business as usual COPD, not just thinking about action plans that support emergency situations, but the patients have goals and they feel confident understanding the strategies to underpin those goals with day-to-day life, not just when they're threatening the ED room. So if I hand back to Sally for our summary, and I'll take a peruse of the questions.
Thanks, Claire. So hopefully we've been able to manage to convince you between us that there's a lot of merit in non-pharmacological interventions to reduce the symptom burden and improve the quality of life in patients with COPD. And there are key interventions that really should span across all stages of COPD management, but obviously early smoking cessation advice and appropriate referral to a pulmonary rehabilitation programme. And I think, supported self-management at the point of diagnosis is absolutely crucial with this combined approach with families, caregivers, to really maximise the success of a self-management strategy. Claire, I'm going to ask you if you've got any questions, or I'm happy to have a quick peek as well.
So we've got a question from one of our viewers asking if pulmonary function tests are required to confirm COPD, recognising that early and accurate diagnosis is absolutely imperative. Breathlessness can come from a range of organs and a range of diseases, and recognising that gold standard diagnosis for COPD is history and spirometry. Would advocate that as part of the diagnosis, but recognising that history taking it remains an important part of diagnosis. And another question, just thinking about, although pulmonary rehab is universally recognised, what do we feel the key barriers are and how can they be overcome?
It's interesting, isn't it? I think there are multiple barriers. I think referral is clearly a huge challenge. Less than 10% in the UK, less than 10% of the eligible population are referred to rehabilitation. And in the US, I'm fairly confident the data is even lower. So I think that, we have to create the demand for rehabilitation. So part of that is working with referrers to engage them in the conversation around the value of rehabilitation to drive up the demand for the intervention. And that's quite challenging. It refers back, Claire, to what you're saying about motivational interviewing almost. And we have post-COVID, there's clearly been a huge interest in alternative ways of delivering rehabilitation. So I think it's not just about the centre-based rehabilitation anymore. It's about widening the scope. And I would always encourage a patient to go and have that initial assessment where they will see the expert in rehabilitation to have that discussion. I think the role of primary care is to get the individual to the assessment. Then there's the whole issue around capacity, maintenance, delivery, globally in low-income countries. I mean, I could go on forever, Claire.
I think it sounds like it's really important that we give patients the knowledge to understand why non-pharmacological options might improve their breathlessness, and also recognise that that's not a one leaflet strategy for education. It's really important that we give patients supported education. We ask them what their goals are, and we follow up with their goals and how they're getting on once we have signposted them onto pieces of information. So thank you so much for your time this afternoon and this evening. I understand that you can claim the CME credits if you fill out the evaluation form, and your feedback's always really helpful, so thank you for your time to do that. And to let you know that on the 19th of May, there's another live stream looking at the pharmacological management of COPD, and that's hosted by Dr. Holmes and Dr. Magnuson. So I look forward to joining into that webinar and learning all about the pharmacological options as well for COPD. Thanks for your time.